I'm Jenna Didel, and I'm the VP of Programs and Community Impact here at the Davis Phinney Foundation. One of the topics we receive questions about from our community, both from people living with Parkinson's and from their families alike, is mortality. It's a topic that can be hard to talk about and one that is often overlooked. We wanted to create a space for those questions to be answered honestly. Dr. Benzi Kluger is a leader in neuropalliative care who brings both directness and compassion to this topic. This conversation covers end of life, what to expect, and how to prepare. These are difficult but important topics. It's okay if now isn't the right time for you. You can step away, come back later, or use the chapter markers to find the parts that are most relevant to you.
Anytime we're talking about end of life or dying, whether that's in clinic or education, I do like to start by asking people's permission or giving them permission to leave, because there are some people who don't want to think about it, don't want to hear about it, and that's totally fair game. Death can be a tough thing to talk about. It can be a scary thing to think about, and so just want to put that out there. And there are some times where a person's family members want to hear a lot about this, but the patient themselves doesn't, or vice versa. And so, and any of those things are definitely fair game. Parkinson's is the 10th leading cause of death for people over age 65. It's the 14th leading cause of death overall for people in the United States. And I think some of the misconceptions come out. What I was taught in medical school and what was on a lot of prominent websites for a long time is that people don't die of Parkinson's, they die with Parkinson's. And that's confusing because a lot of people with Parkinson's have seen people in their support groups who've seemingly died of Parkinson's. And yet their neurologists didn't say that, or they went to a website that told them otherwise. And I think the harm in that misconception is that if you don't think you can die of Parkinson's, then you also won't be prepared to die of Parkinson's. And I think our healthcare system doesn't help things because I think oftentimes our healthcare system pretends like death is optional. And there's always one more thing that could be done to keep life going. But unfortunately, we don't really have a choice of if we die. We don't have a lot of choice of when we die, but we do have some choice of how we die. People with Parkinson's, at least from data a few years ago, we're going to see if this has changed, were more likely to die in a hospital or a nursing home than they were to die at home, almost by a 4-to-1 ratio. And if you ask people, if we were to ask our listeners right now to raise their hands if they wanted to die in a hospital or in an ICU, we would see very few hands. Oftentimes no hands, sometimes one hand. But most people, when they think about a good death, they want to spend as much time as they can at home. They want to be surrounded by their loved ones. They don't want to be in a hospital. They want to be comfortable. And if we're not having this conversation, then that opportunity is robbed from them. It's dangerous for a few reasons. One, I think it's dangerous for healthcare providers. If your doctors and healthcare professionals aren't thinking about this, aren't looking for it, then you, as somebody with Parkinson's, or you as a caregiver, are likely to have a poor end of life experience and may not be getting the best guidance on decisions that you should be making. Oftentimes, people with Parkinson's wind up going in and out of hospitals and nursing homes in their last 6 months of life, and it's just not how people would want to spend that time, if they knew where they were in their disease. And I've found actually patients and their families oftentimes even have a better sense than their doctors do about where they are, that they may come to see me. I'll be as frank and honest with them as I can. And I say, I'm sorry to say this, but I think that we might be getting close to months. And these are the things I'm saying, and this is why. And they would say, I was thinking the same thing. I would say there's occasions where people are surprised by that, but I would say more often than not, people aren't surprised by that. And they said, I'm glad you told that to us, because we were thinking that, but it didn't seem like anyone else wanted to talk to us about that. Yeah, there's kind of two sides to that I think are worth thinking about. There's a personal side to having a good death, and when people are asked, what does a good death look like to you? It's oftentimes being surrounded by family. It's having control and dignity. It's not spending time in and out of the hospital getting medical procedures. It's having symptoms like pain well controlled. I think if you were to expand beyond that a bit, and this is actually one of the founding principles of palliative care, is to help people to live until they die. And for me, it goes into wrote a paper called The Total Enjoyment of Life. And the reason I wrote that paper is that I wanted doctors and patients and family to be as systematic and comprehensive about thinking about joy as we are thinking about suffering. So that could be, eating more ice cream. That could be enjoying more sunsets. That could be spending more time with your family. That can be, simple things like holding hands more, reading, writing or telling stories for your children, for legacy, leading into meaning, where you found value in your life. Um, there's a really moving book by Ara Bjork. I believe it's called The Four Things, where he talks about four things that people oftentimes wish they said or need to say before they die, which are I love you, thank you, forgive me, and I forgive you. And so there's also this opportunity for reconciliation and for healing. And I think all of those things kind of fit into this personal side of a good death. For some people, there's an opportunity for spiritual growth. Sometimes people want to work with a death doula. Sometimes people may want to work with their spiritual community. But I think part of a good death from a spiritual side is being able to come to a place of peace and acceptance, and whether that involves, your understanding of what happens after you die, or falling into mystery, or whatever it happens to be. All those things I think are important, and I think all of those things on the personal side help people be able to let go. How do you support somebody in letting go? Which is kind of, again, this paradoxical thing, and it's this very bittersweet part of life. But I think if family are able to talk to their loved one about letting go, about giving permission, about letting them know that I'm going to be okay, that we're going to stay connected, that can also make it easier for the person who's facing the end of their life. So those are kind of all some kind of thoughts and considerations on the personal side of things. There's another book that I love called The Five Invitations, um, that has lessons from the founder of the San Francisco Zen Hospice. And a lot of them are about, really going into the tough stuff, not being afraid of sadness and what's bittersweet, seizing the moment, doing what you can today. And I think they're just generally good advice for living, and living a more full life. But I think when you have that timeline, sometimes paradoxically, you're actually enjoy life more and you appreciate daily pleasures more, because now you're confronted by the finitude and the briefness of life, that it's not going to be forever. And then on the medical side, for most people, less is more. And for most people, spending less time in the hospital, less time with doctors, more time at home, more time with family, taking less medications is what's most important. And so that could involve initially starting with palliative care or a palliative care clinic, but then oftentimes could proceed to hospice. And hospice is a program, it's paid for by Medicare, Medicaid, all insurances, that provides essentially home care for people who have a 51% chance or more of dying in the last 6 months of their life. And I say that the 51% chance because you can live longer than that. My record holder on hospice lived for 6 years. I've had people who've graduated hospice and actually did better after they were on hospice. But hospice provides a lot of tools and support to keep people at home. And that's another important thing to realize with hospice, that 95% of the time it's at home. It's not a place you go to, it's a service that comes to you. And their number one job is to keep you out of the hospital and make sure that you don't have needless suffering, that you're not in pain near the end of your life, that you're not dealing with things that are overwhelming to you or your family. Great chaplain Ryan, who I've worked with when I was at Colorado, is asking the question of, are you afraid more of what happens before you die, meaning the process of dying, which can sometimes be a fear of pain, fear of choking. We can kind of talk about how people die when they die of Parkinson's. Or is it a fear of what comes afterwards? So a fear of the unknown, a fear of leaving their loved ones. And for some people, the fears that they have are they're financial. They're worried about what's going to happen to their family. They're worried about if they're going to be in a nursing home or need extra care. So there's, sometimes things kind of fall into that logistical bucket. And I think, for myself and our palliative care clinic and in hospice, certainly, one of our goals, one of the questions I always ask people is, are there things that you're worried about or that are keeping you up at night? And so for the things that happen before you die, myself or a hospice doctor can be helpful for that. And we'll do our best to make sure your pain's well managed, and we'll do our best to make sure that you and your family knows what's happening, and that we do our best to keep you as comfortable as possible. If it's for what happens afterwards, then that's where we bring in our chaplain who to kind of talk about, the more existential and spiritual aspects of things. And if it's the financial parts, then, it's our social worker who might be the most helpful to really help guide a patient and family through, how are you going to make it through this? What are the potential costs? What resources might be open and available to you to help provide extra care at home during this process? I suspect it's something that more people want to ask than actually ask it. Um, I had a talk that I did before about I'm trying to remember what it was called, sex, death, and drugs, things that you're afraid to ask your doctor, and we kind of went into some of these topics. But yeah, it is something that people worry about, and I would say that more often than not, the reality of how people die is less horrific than their imagination of what might happen. So I would say the most common fears that people have with how they might die of Parkinson's, one is choking to death, which is, an awful thing to think about and unfortunately is very rare. Another is that they're going to lose one neuron at a time until they stop breathing, and that it's going to be this very prolonged process, and they're going to spend a lot of time not being able to do anything that's meaningful to them. And I think maybe a third fear is that there is going to be a lot of pain and anxiety around the end of life. And in my experience, and the data suggests that for all three of these things, unfortunately, those things almost never happen. The most common cause of death and the most common setting of death is that as people with Parkinson's progress, the things that I see that are a red flag that make me think maybe we're getting close to hospice is oftentimes people are sleeping a lot more, sometimes 12, 16, 20 hours a day. They're more withdrawn. They're less interested in eating. They have weight loss. Their progression is accelerating. So patients and families will tell me that I've lost more in the last 3 months than I did in the past year. Oftentimes they're getting to a point where they're wheelchair bound and then potentially bed bound. And I think in some ways, mercifully, that there is this acceleration. And I think doctors and patients oftentimes get it wrong, thinking that there's going to be this straight line, that things are just going to keep going at the same rate. And I think it's a problem for doctors because then they misestimate when hospice should start. And they start hospice way too late because they're not anticipating this acceleration or snowball effect. And I think it's kind of a blessing in disguise for patients because it means that the worst part of the illness is also going to be the shortest. Um, and to kind of go into the other things, so once people kind of cross that line, aspiration pneumonia, which means that things are usually saliva are going down the wrong pipe, oftentimes at night, it's also called silent aspiration, is kind of the proximal cause of death, which is not choking. People don't recognize it. And it's also something that, you can treat, but if you've reached that stage where you're no longer able to protect your lungs and swallowing, you can't cure it. And so sometimes what that looks like is people going in and out of the hospital and nursing homes a lot towards the end of life. What it ideally, I think, looks like is that people recognize it either before or with the first hospitalization and say, let's stay at home. We can treat you with antibiotics if things come up. But, I think this is really a sign that, we're getting towards the end and let's try to make that time matter as much as we can. So, yeah, UTIs are not uncommon. And sometimes that can lead to what's called urosepsis as a cause of death, and sometimes people will have these recurrent urinary tract infections, which could be a sign that we're again getting close and that we might not be able to fix it. Although we've had patients where we've got them on a good regimen of antibiotics and have been able to give them some more quality of life. Falls come up and are definitely something that we want to take seriously. We want to make sure that people are safe at home. And there are things, where people with Parkinson's die that we can't anticipate or plan for. And so I think even in our clinic, even us doing our best, that there's probably 10 or 20% of people with Parkinson's who die in the hospital. And that could be an unanticipated fall with a hip fracture or a bad bladder infection. So there are things that come up that we can't anticipate, but I think for the vast majority of people, there's a lot more that we can do to make things better and plan in advance. Speak to one thing that I actually neglected to mention with the medical side of preparing and planning for a good death is doing advanced directives. So putting in writing who you want to be your healthcare proxy, and another way I would put that is who you would want to be your voice if you're no longer able to speak for yourself. And I use that term purposely. I learned that from Gene Kuttner, who's a palliative care doctor. But it's not about having someone making decisions for you. It's about somebody who can bring your authentic voice into the room when you're really sick. And I think that's important as you're choosing who you'd want to be your healthcare proxy, because you really want somebody who's going to make the same decisions you would make. And I've had the situation come up where people have not chosen their spouse because their spouse would either keep them alive a lot longer or a lot shorter than they would have wanted. So they might have a friend or another family member do that. Um, so getting the healthcare proxy and having those conversations with your family are important. The other side of that is that calling it someone's voice is it reduces the amount of guilt and pressure that healthcare proxy feels when their doctors say, do you think your mom would want to be on a ventilator, or do you think your mom would want X, Y, or Z? And they could say, I talked to her about it. She told me in no uncertain terms that she does not want to be on a ventilator, particularly if it's going to lead to her staying in a nursing home. So if my mom was here, I would say no. And one of the things I do as a palliative care doctor sometimes is what's called the empty chair technique, is rather than ask somebody to make a decision, I ask them to imagine that their mom of 5 years ago was there in the room, and what would their mom tell us? And sometimes their mom tells us something very different than their initial instinct for a decision. Like they would say, my mom would say, "Oh my God, what the hell am I doing there? Like, get me out of here." Yes, exactly. And then that oftentimes makes things very, very clear. And so it's about let's do what your mom would want. Not about, this decision falling on your shoulders. The other part of that, which is you can fill out, is a living will. In different states, there's something called the POLST form, POLST, or the MOLST form, or the MOST form, but these are all medical orders on life-sustaining treatments. And for some people, as they near the end of their life, they may say, if my heart stops, if I'm not breathing, if I'm dead, then allow a natural death. I don't want CPR. I don't want resuscitation attempts. And I think in talking about it, I always let people know that in the real world, unlike on television, when people get CPR, it's about 50% of people survive CPR or even make it out of the hospital. And of those who do survive, it's maybe 5 or 10% who get back to something close to their life prior. CPR was not designed for people with Parkinson's, so those figures are probably lower. And so it's really a decision about what kind of chances you would like to take. But for a lot of people, there's a point in terms of quality of life and in terms of their health where doing CPR, spending time in an ICU, being on a ventilator just doesn't make a lot of sense and makes it much more likely that they're going to have a bad death. Part of it depends on how old you are when you develop Parkinson's, and part of it depends on what other health conditions you may have. The length of life that's shortened also kind of ironically is determined by your age. And so if you're 30 years old when you develop Parkinson's disease compared to other 30-year-olds, your life expectancy may be shorter. But that being said, you may still have decades in front of you. I guess the last thing I would say about it is that we don't have a crystal ball. And the way I think about things is, does somebody have decades, years, months, or days or weeks to live? And for most people with Parkinson's, if we're seeing them early in the illness, that they have decades in front of them. And so they may have a potentially on statistically a few years trimmed off of their life because of Parkinson's. But in general, for those people, I really try to focus on how can we live our best life now? How can we be as active and independent as possible? And I feel like all of those things help people to live not just better, but also longer. As we get into more advanced phases of the illness, and when we're talking about years, those might be a time where, people's mobility is worse. They're using a walker. They might be developing thinking and memory problems. They might be developing swallowing problems. Um, and that at that point, that Parkinson's may be the more likely cause of their death. And that's definitely my mindset when I see people, and I'll tell them about that, and we may have a conversation about that if they're open to it. Um, when people get into the months range, that's when we start seeing weight loss, sleeping, accelerating decline, where we might start thinking about hospice. And then when people have more days to weeks, we're seeing people, with very little appetite, sleeping most of the day, very withdrawn. And then, certainly when we get to days to hours, there's other physiological signs that indicate that we're getting near death. And so the closer we are to death, the better our predictions are. But that, I guess a long-winded answer to say that nobody has a crystal ball. And depending on kind of which of those categories you fall into, might kind of shift your focus. Yeah, as you know, it's a controversial topic. It's definitely a very personal decision. It's also something that people with Parkinson's and people with neurologic illnesses think about quite a bit. And in the state of Colorado, the medical aid in dying law was pushed forward by somebody with Parkinson's. Across the country, a lot of the medical aid in dying laws were pushed forward by people with neurologic illnesses, including Parkinson's. And I think part of that is that when people look at why people chose medical aid in dying, the most common reason is not pain. The most common reason is loss of the ability to do joyful activities and loss of independence. And I think part of that also speaks to, kind of my approach to it is people are, in general, not choosing medical aid in dying because they're afraid of death or they're, afraid of pain. They're choosing it as a way to reassert their control in the face of an illness that has taken away a lot from them. And they are people who are not afraid to look death in the face and who have very well-defined ideas about what it means to live a good life, and that they don't want to cross that line from living fully to just merely surviving. So the people that I've worked with, I actually initially kind of defied my expectations of the people who might be asking for medical aid in dying. When I get those requests, the questions I always ask people, one is why now? And what's going on that's making you think about it? Are there things that we can do? And this, I think, is critically important, no matter what your views are on medical aid in dying, is that if somebody is thinking about this, let's try to understand what is the suffering or the fears that are driving this, and are there things that we can do that might be able to address it? A lot of people who even get the prescription for medical aid in dying, about half of those people don't use it. They just want to know that that option for control is there, and if they get good palliative care and if they get good hospice care, they may never need to use it. So that I think is an important point. And then ultimately, it is a very, it's a very personal decision. And I've certainly worked with families and I've helped families who've chosen that option, and I've gotten good feedback from those families that it really did meet their goals and expectations. But it's certainly not something that I would, promote or push on anybody. Particularly if it didn't seem like it was aligned with them and their values. And the vast majority of people with Parkinson's that I work with are able to attain what I think they and their family would consider a good death without medical aid in dying.